Hello, I'm Dr. Randall Sechrest, your host for eOrthopodTV, and today we'll be talking remotely once again with Dr. Erik Nilssen. Dr. Nilssen is an orthopedic foot and ankle surgeon who practices in Gulf Breeze, Florida. Dr. Nilssen did his medical school training at the University of South Florida, and from there an orthopedic residency at McGill University. And from there, 2 fellowships, one in sports medicine at the American Sports Medicine Institute with James Andrews, and another in foot and ankle surgery under the direction of Angus McBride. Thanks for joining us again today, Dr. Nilssen.
Oh, my pleasure, Randall.
Well, Dr. Nilssen, today what I thought we would start talking a bit about is Achilles tendon problems. And I think this runs a gamut. A lot of people have heard of Achilles ruptures and that sort of stuff, but I think that there's more than just the ruptured Achilles tendon that you and I worry about as orthopedic surgeons. So let's start out by talking a bit about what the Achilles tendon is and what its function is.
Sure. It's a very important structure in the body. As most of you know, it's that real thick, big cord in the back of your leg that runs down their calf and actually inserts in the bottom or back of your heel. Otherwise, the bone's called the calcaneus. But what it does, it's an interesting structure. It actually originates, the muscle bellies originate above the knee, called your gastroc muscle. And there's a medial and lateral head, and as it goes distal, muscle turns into tendon, and then the tendon attaches to the bone. And there's also a muscle underneath it called the soleus muscle, which actually turns into the tendon as well. So it's really 2 different muscles, but attaches to that cord, and it's a really powerful plantar flexor. So pushing on the gas pedal, being able to jump, so even to walk. So it's a very, very powerful structure that's very needed to carry on activities of daily living.
And the type of problems that people have with the Achilles tendon, can you sort of give us a broad overview of the sorts of problems that we're going to be discussing today?
Sure. I mean, just like I tell my patients, when you talk about tendons, I always try to keep it very simple. And so I tell everybody tendons can do 3 things. They can tear, they can get inflamed, which is tendonitis, or they can get diseased, which is tendinopathy. So those are the 3 things that we'll kind of touch on. And then in a sort of another broad view regarding the Achilles tendon, kind of back to the anatomy of a tendon, the Achilles tendon is much like an onion. Okay, you know when you buy an onion from the store, there's a covering of that onion, and we call that covering a peritoneum. It's just a structure that helps the tendon glide and doesn't get stuck to the skin. So there's a covering over that tendon called the peritoneum, and inside that tendon is like the layer of an onion. It's collagen, and so that collagen is very, very well organized, much like an onion. As you go to the layers, very well organized. So I use the onion analogy. Well, much like the onion, the tendon can get something called peritendinitis, and so that sheath can get inflamed. That's one of the major problems. Number 2 is the onion itself can get diseased, and we call that tendinopathy. And then you can get a combination of both. You can get that tendinitis or tendinopathy together. So the sheath, like the onion sheath's inflamed, and also the onion itself is diseased inside. And then you can get what's called a bursitis, where it attaches down below the heel. You can also get non-insertional Achilles problems and insertional problems, like we talked about, where the tendon comes down, and you can have a problem just above where it inserts, or you can actually have it where it inserts. And so, anywhere along that tendon can have a problem, but we break it up into insertional, non-insertional. Is it an inflammatory problem? Is it a non-inflammatory problem, a disease problem, or a combination of both?
Well, let's help patients understand this distinction you've just made, because I think this is key, and that's the difference between Achilles tendonitis, for example. We tend to talk about a lot of things as tendonitis or some type of itis. And then you mentioned the term tendinopathy. Can you help patients understand the real difference between those two disease processes?
So, as we understand it today, and this just recently changed a few years ago, but so tendonitis, someone says, oh, you got, your shoulder hurts, oh, you got rotator cuff tendonitis, or your patella tendon, you got tendonitis. Tendonitis is an inflammatory problem, means there's inflammation, okay? And we talk about inflammation, we know now that the inflammation that occurs is on the outside of that tendon, that covering, that peritoneum. That gets inflamed, okay? That's an inflammatory process. Now, unlike an inflammatory process, we say tendinopathy. The actual tendon itself, the actual structure, not the outside, but the inside structure, like I said, is made of collagen, a very well-organized structure. Well, when it gets diseased, it's kind of chaotic. It's almost like, you know, when you set up your computer and you've got all these nice cables in the back of your even your TV with your home stereo system. You got speaker wires, cable wires, all very well aligned in a nice parallel form. Well, imagine that. Remember, over the course of a year or two, somehow your kids hook up a Wii station. Next thing you know, you've got wires going everywhere. The structure of the tendon itself, that's tendinopathy, just gets chaotic, and it gets thickened, and the structure doesn't look the same. And so that's disease of the tendon. That's tendinopathy. So the tendon structure itself is diseased. It loses its normal anatomy, whereas the tendonitis, again, is more of the sheath covering gets inflamed. It's an inflammatory process.
So, and now let's talk a little bit about the rupture. And I'm assuming that everybody probably understands what a ruptured Achilles tendon means, but clarify that for us a bit.
Sure. So, you know, someone says, you know, you've ruptured your Achilles. And so just as we just talked about in this disease process, when it gets diseased like that, and we call it tendinopathy, you know, it's my belief and many others that you're getting microscopic tears in the tendon, and the body's trying to heal these microscopic diseased areas or microscopic tears, and it gets thickened and full of just diseased tissue. Now, an acute tear, when someone says, oh, you ruptured your Achilles, you know, that's where the Achilles actually just tears in half. And usually what that is it's not, you know, it's classically someone eccentrically loads their Achilles tendon. So they're playing volleyball, and you step back and you abruptly try to push off and fire that Achilles, and you feel a big snap. And everyone tends to think that somebody or something hit them in the back of the leg, really just above the heel bone. And so oftentimes, you know, I've had patients that are volleyball players, and they think someone kicked them in the back of the leg, or someone was stepping out of a pothole and they feel like the pothole cover flipped back and hit him in the heel. But the reality is it's such a powerful structure. You can audibly hear the snap, and they feel immense pain, and they don't have the push-off strength. That's an acute tear. That's a rupture of an Achilles tendon. Same thing in a tear and a rupture. We're talking about the same deal. There's an acute, means it just happened within, you know, a week or two. And then chronic is when it's been torn and they kind of neglect it, and they come see you weeks to months later.
Now, are you of the opinion that you can actually rupture a normal Achilles tendon? Is that something you see commonly in athletes, or do you assume when you see an Achilles tendon rupture that maybe that tendon was a little bit diseased before it ruptured, or both, I guess?
Yeah, I mean, it's you know, populations, I mean, it depends on what they do for a living. I mean, we have the athletic population and even the non-athlete. You know, obesity is a big problem with Achilles issues, and so generally speaking, the blood supply to the Achilles tendon is such that about 2 to 6 centimeters above where the Achilles inserts, there's an area where it gets less blood supply. It still gets blood supply, but it's not as good as the other areas, and so that's usually the area where we see problems in the Achilles, and so that's usually where it ruptures. And so when someone has an acute rupture, you know, we go repair those. Oftentimes, if it's a younger patient, they could have normal tendon, and they just rupture because they had some, you know, pretty impressive event. But a lot of times, too, there's people that have some early disease process. You know, for example, you know, an NFL player or a college football player, them playing football their whole life, putting on this extra wear on this tendon, they can tend to have a little bit of disease process before. You'll ask them, they'll say, well, you know, I had some pain prior. Or even more than that, they'll have some contractures. They'll actually have a very, very tight Achilles, and then they're sort of susceptible to tearing that.
Well, let's move on and talk a little bit about the other symptoms before the tear. As you mentioned, the tear is pretty easy to spot. You feel like somebody kicked you in the back of the calf, and all of a sudden you can't push off on your toe. But what about the tendinopathy and the tendonitis? What do people present to your office? What type of symptoms do they present with when they come to your office for Achilles tendon problems?
So usually when patients come, if they have, you know, we say non-insertional Achilles, so that's where the tendon, we're not talking about the insertion site, we're talking about a little bit higher up, maybe 2 to 6 centimeters above the insertion site. So when they have a tendonitis and tendinopathy, a lot of the times the symptoms will overlap. And so, but with tendinopathy, over time, you tend to see a much thicker Achilles, or you'll see almost like a bump, you know, almost like an hourglass. The Achilles comes down, and then it has an hourglass and then comes back down again normal. So, but they'll complain of pain, they can actually walk and do things. When they try to do activities, run and jog and push off, it starts to escalate, really escalate. So pain is the biggest thing. They can still function, but they've got pain with function, whatever they do, walk, run, jump, and it becomes to get more of a chronic issue, and they tend to be taking lots of anti-inflammatories trying to get through this, and they come to you after a year or so. But that's non-insertional. Insertional problems, same deal, where the Achilles inserts in the back of the heel, they can get, people call this thing like a pump bump in the back of the heel. They can actually get a real thickened area in the back of the heel and have this big protuberance in the back of the heel that's quite sensitive to touch. The back of their shoes won't want to touch the back of their heel. They become very sensitive, and so they'll wear almost backless shoes or heels that have a little bit of a heel lift in them to take pressure off the back of the heel where the Achilles is. And that's the insertional findings we see versus the non-insertional.
So in terms of these types of problems that don't involve a rupture of the Achilles tendon, how are you going to evaluate that when that patient shows up in your office?
So classically, I'll look at them and look at their, again, I completely examine, have them walk, have them do heel lifts facing away from me and look at their heels. And again, if I always compare one to the other, and so you want to look at both sides, and you'll see sometimes if it's a non-insertional problem, you'll see sort of a bogginess of that tendon. Usually if you look from the back, there's not much padding back there, so the tendon's very, very close to the skin, and you can see the contour of the Achilles very well. And as you stand there and watch them from behind, you can look at the, quote, normal side versus the abnormal side and see more of a thickened area. You don't see that well-defined area. And then exquisitely, when you sit down, you try to, you can just start palpating that Achilles, and if it's non-insertional, wherever their disease problem, whether it's insertional or non-insertional, they're exquisitely tender to squeeze that tendon. And if a tendon looks normal, the normal size, I tend to think it's a tendonitis problem. When it's thickened, then you think this disease process like a tendinopathy. And then in the insertional side, it's the same way. You palpate medially, centrally, and laterally, and usually they've got this, horrific pain to palpation and very, very sensitive to touch back there. So that's typically what I do. And then to be complete, you can place them face down on an exam table and bend their knees and check the resting tensions of their Achilles and check their hamstrings as well, because oftentimes they'll be very, very tight hamstrings, tight Achilles, which I think can help lead you to Achilles problems. Also look at foot structure. People that have flat feet or high arched feet, either way, the flat feet can put an excess pressure or tightness on the Achilles tendon as well and can lead to these problems.
And what about imaging? Do you normally go ahead and get x-rays of the foot and ankle? Do you ever do any type of special test like an MRI scan?
Yeah, so I classically, for new patient visits, just standard get an x-ray. It's cost effective, and if there's an insertional problem, it's very effective because oftentimes what you're looking for is, it's nice to see if there's usually you'll see a heel spur that's going, and really what it is, it's a traction spur, and the tendon's actually, it's grown into the tendon, and you can imagine that it's like a rope that's attached to a wall, and it's just constantly being pulled your whole life, and as you walk and run and jump, it's pulling even more. And so those that have this disease process, you'll often see this heel spur in the back, which is, it's good to know that it's there, or a loose body or some sort of bony spur if you're ever going to do some surgical intervention. But a plain x-ray. Other than that, other modalities are ultrasound, much more cost effective than an MRI, but it's user dependent, so unless you have a good ultrasonographer around and very skilled, they can kind of tell you if there's swelling around the tendon itself, like the tendonitis, or is it actually the tendon itself that's diseased. But my go-to scan usually is an MRI, and the MRI is the best test we have that's non-invasive, that will tell you if there's some signal changes in the tendon, to tell you if it's diseased, how thick it is, what it looks like around the tendon. So it gives you a much more detailed view of what's going on. So X-ray, ultrasound, or MRI, these are but I don't really do ultrasound, it's an option, but I go with an X-ray and then even an MRI as well.
And what about if you suspect a complete rupture? Is there anything else you do different to evaluate that patient?
So a complete rupture, if it's acute complete rupture, my go-to test is I lay them on their belly and bend their knees and look at the side picture, and you'll see the resting tension of the intact foot is quite tense, and you'll see the foot actually plantar flexed, meaning that it's, the resting tension of the foot is actually as if it's pushing down on the gas pedal, whereas when it's completely ruptured, you'll see that foot just kind of flopping almost 90 degrees. And what you can do too is you can actually squeeze the calf. It's called a Thompson sign. You can squeeze the calf, and on an intact Achilles, you'll see the foot sort of pop back and forth. When the Achilles is torn, you squeeze the calf, you really get nothing. And so that's, observation in a resting position on their belly in a Thompson sign. And then classically, they're very resilient to put any weight on it. If you really are unsure, have them put weight on it and see if they can push off. And also, you can just palpate. You usually can palpate this nice contoured Achilles throughout the entire length of it on the normal side. And then on the injured side, you can palpate, and you'll palpate a nice gap where you can actually feel the two ends of the Achilles. And so that's my physical exam.
And if you suspect, based on your physical exam, that this is a complete rupture, do you go ahead and do an MRI scan? If you know you're going to do surgery on this, do you go ahead and order an MRI scan to get more detail?
Yeah. So for me, I don't get an MRI. Some people do. I don't. I know it's torn, and in my practice, if it's an acute tear, I go ahead and fix it. I really don't discriminate based on age or anything like that. I mean, if someone's fairly unhealthy and the risk of surgery is quite high, and they've got some serious cardiac issues or have had heart surgery before, and they're just very low demand, patient doesn't walk much, I may second guess taking them to surgery. But in fact, we're doing this interview now. I just had last week, I had a very active 76-year-old gentleman, very active, tore his Achilles acutely and was going to be treated in a cast, non-weight bearing, and I saw him, and very healthy and active guy. I fixed him, and so we know that acute tears fixed surgically. I just feel it can sleep better at night that I do get a good repair. I can get those tendons together, whereas non-operatively, they have a higher incident to re-rupture if you don't fix them than you fix them, which is quite interesting. But there are some studies out there that say, well, maybe long term they do the same. But right now, I think most people out there, acute tear, as long as they can handle surgery, will be fixed. It's about a 30-minute procedure, and it's the only risk with surgery really is your there's not much padding back there, and you worry about infection is the biggest thing. But we knock on wood, I haven't had any of those. So.
Well, let's go back and talk a little bit now about the treatment of the non-rupture types of Achilles tendon problems. So when you're dealing with tendinopathy and maybe tendinitis, how are you going to start out treating that patient?
So it's interesting. I mean, we talk about the tendinitis aspect of Achilles and then the disease part, and we sort of treat both of these kind of the same in the sense that so tendinitis, it's a young active person comes in. Obviously, number one, you want to get them on. I get them on some kind of anti-inflammatory because it's an inflammatory process. If it's tendinitis, rest, ice, activity modification is the biggest thing. And if they're very, very sore, I will try to maybe get them in a boot or some type of immobilization for a short period of time just to get things calmed down. And then I get them in what's like a physical therapy program, or get them with a therapist where they can show them a lot of stretching exercises and do some we call them eccentric contractions of the muscle. And really what that is, it's basically, imagine someone doing a bicep curl and somebody, as you're flexed, slowly pulling down on the muscle, so your muscle's actually elongating but while you're actually contracting it. So eccentrics, we know, have a very, very good effect on tendon problems, specifically the Achilles tendon. And so, but for the non-inflammatory or the diseased aspect of Achilles problems, it's interesting. We still put people on anti-inflammatories, but we just said it's a non-inflammatory problem. So it seems kind of strange why we do that when it's a disease process. But there is some pain effectiveness of anti-inflammatory, so I think we do it for that. But either way, but much more aggressive therapy, much more immobilization. But I warn patients with the non-inflammatory, the disease part, they have a nice big tendon that's thick and real sore in their heel. I tell them we're probably 50-50. I mean, we can do therapy, we do immobilization, anti-inflammatories. We don't inject steroids. Steroids are no-nos in tendons. They can rupture. So a corticosteroid injection in the tendon itself will rupture it, so I don't do that. So we do, a good 6 to 8 week therapy program. If they have any success, I keep encouraging them to keep doing their home exercises, activity modification, all that stuff. And then till they get to the point where they just can't handle it, then we move to the next step. But those are my non-operative treatments.
And with the exercise, what are you actually trying to accomplish with the tendon, especially with the patient with the tendinopathy, the changes in the tendon? What do you think physical therapy does to that disease process?
I think the biggest thing it does is it, a lot of times, like I said, these patients are so contracted, and all of us, I mean, how many people that you even know, stretch every day? Most people don't, including myself. So I think the biggest thing therapy does is it allows, it gives that tendon more attention, if you will, for stretching standpoint. So we're looking for a much looser tendon. If we can get them to stretch that tendon out 5 or 10 degrees, meaning that if you can dorsiflex the foot about 5 or 10 more degrees closer to your face, it's going to take a lot less pressure off that tendon itself, that resting pressure, and off the heel. So stretching is one thing, getting more length out of it, and then also contracting that muscle, contracting it under controlled, like on a controlled eccentric way that we talked about. I think you're not really going to shrink the disease. The disease process, a lot of it has to do with vascular issues, getting blood supply and healing factors to that disease process. And so in terms of increasing blood flow to that, we don't really have, at least I don't know, good scientific data supporting the use of that, but we know that really just getting them at a higher resting strength and increasing the strength and contracture of their heels does make people better, but that's what we're hoping to achieve.
What about this new platelet-rich plasma treatment that I think people are probably going to have heard about? Do you see any benefit to that, to Achilles tendon problems?
Yeah, it's actually an option that we even use today, and I use that. I think it's a nice product. We're still trying to figure out. The problem with the PRP is there's different concentrations. There's companies that make, it all has to do with the rate at which you spin the blood and the concentration of the platelets, and so it all has to do with that, and there's really no standard. So you've got, everybody treating these problems and using PRP, but we don't have we're not using the same concentrations because different companies have different spinners, and so that's a problem. And there's a lot of times you don't know what you're using, and 10% of the time you can use PRP and you're not even getting platelet concentration in that, which is a very interesting study done out of Cornell. So if 1 out of 10 we're not even getting platelets, I mean, that was mind-boggling to me. I found that out a couple months ago. So when I use it, we take the blood, I actually look at it under the slide, make sure we do have platelets in there, and then we also have a cell counter, so we try to get a concentration a known concentration. But it definitely has its place. There was a study that showed it for Achilles, they used it, and there was no difference, but there was a tremendous difference in plantar fascia. But again, you got to look at what concentration they used and what company they used. But we're actually doing some studies now, trying to have a control versus non-control, and actually use and record our concentrations that we use. But I definitely think there's a place for PRP, and the problem with it too is all the growth factors that are in the platelets that can help heal. There's so many different growth factors, but isolating those growth factors that actually help form tendon or help form vessels, pretty soon we can break it down where we can maybe just isolate those. We're ways away from that, but it's very promising. But there is a role for that for sure.
Now, you mentioned the difference between the problems that involve the tendon itself just up from where it inserts, and then the insertional type problems. Do you treat the insertional type problems any differently at this point?
Well, if it's an insertional problem, we look at least I try to figure out if it's an insertional problem, I'll get an x-ray looking for that spur, and then potentially if it's an insertional problem, if we end up getting an MRI, which I'll do, I want to see if the tendon itself looks diseased on the MRI where it attaches to the bone, or this concept of this, we call it a retrocalcaneal bursa or a bursitis. And so, looking at your heel, you've got skin, you've got a little bursa sac, which helps the skin from rubbing on the tendon. So it's skin, bursa, tendon, then another bursa, and then bone. And those bursas keep the skin from rubbing on the tendon, and then rubbing from the tendon on the bone. And sometimes you can get a very inflamed bursa, which hurts back there, and you can palpate on that, and people be fooled and say, oh, you have insertional Achilles problem, or you have a diseased tendon in your insertion site. Well, in reality is they just have that inflamed bursa, which on that situation you could try to inject just the bursa under ultrasound guidance and get some numbing medicine, maybe some steroid or something in that bursa to help calm the bursa down, which has no risk at rupturing the tendon at that point. But so I will treat the insertional stuff from that standpoint a little different, but I want to pinpoint exactly, is it, what are we treating? Are we treating a bursa problem? Are we treating an inflamed skin area, just an area that, like a trigger point that's just sensitive? Or are we treating a global area that we have a diseased tendon in? So it depends on what it is, but I do treat those a little bit different.
Now, you had mentioned in all these problems, you'll continue conservative care until it becomes clear that the problem is just not improving. What are our surgical options at that point? And let's start perhaps with the substance issues, those thickened tendons with the tendinopathy. What are the surgical options to treat that problem?
So surgically, for the non-insertional, we're talking about 2 to 6 centimeters above the insertion site, so they come in with a real thickened hourglass tendon. For those, what we typically do is we expose that tendon, and textbook answers are if the tendon itself is over 50% diseased, and how we got to that number I don't know, but if there's more than 50% of the tendon that's not normal, okay, then typically we go in there and you cut out typically the disease segment. You take that disease stuff out, and then classically you want to augment that with some healthy tendon. And so you can do tendon transfers. You can borrow, the tendon that flexes your big toe. There's 2 tendons to that toe, but we'll take one of those tendons away and use that as a graft. We call it an autograft, or we'll augment that tendon. And so we'll take some healthy tendon there. Some people use allograft. They'll take cadaver tendon and augment it. Some people will take their own tendon as well, but they'll take from a different tendon. So there's a couple things you can do, but classically it involves debriding some of that dead tendon out of there. So if they just have a pretty healthy looking tendon, but it's just really thick and it's partially diseased, we'll just try to we call it ellipticize. So if it's an hourglass, we'll shell out some of the diseased tendons, so when we suture back together, it looks like a nice straight tendon. And so basically that's the gist of it. And sometimes we'll go up a little higher and take some length out of the Achilles, or take some length, add some length, so it takes pressure off that, and use some healthier tendon that's higher up and transfer it down. But for non-insertional, that's the gist of what we do.
And I'm assuming one of the results of that operation is actually during the healing process to get a little bit more blood flow into that area to sort of create a healing process. Is that accurate?
Yeah, it is. And that's, you're just trying to get rid of the diseased tendon, get some healthy tendon in there, and augmenting with another tendon. Sometimes we transfer that tendon that actually has the muscle belly attached to that tendon and pull that muscle belly down, so you've got nice blood around that muscle belly, around the diseased tendon, which with the hopes of it'll help remodel that tendon and repair it. But also too, that's where you can get in some PRP we just talked about, and after you repair this, putting some PRP right where you have everything exposed, with the hopes of adding some healing factors to that. And there's also some synthetic grafts that are some acellular dermal stuff you can use that can actually aid in some tendon regenerative stuff as well. But yeah, the goal is to get some healthy tissue there, and so the body can remodel itself and repair it as well.
And what about the insertional problems? How does that differ in terms of your approach surgically?
So insertional problems as well, it's a little, and you can get some different opinions on this, and I see it all the time, is it's very daunting when a patient walks into a doctor's office and they say, well, this is the gold standard. You've got an insertional problem, you failed all your conservative treatment, this is what we're going to do. And I hear this all the time, is all the patient hears is we're gonna cut your Achilles off your heel, cut your heel bone and reattach it. And when they hear that, they run. I mean, who wants your Achilles cut off? And that's kind of the gold standard now is you make this incision right down the center, peel everything off and take the Achilles tendon off, and then that heel spur we're talking about, they'll take the heel spur away and they'll cut some of the bone in the back of the calcaneus, the heel bone, to nice bleeding bone, and they'll cut out the diseased insertional part of that Achilles tendon. And sometimes you have to cut out a couple centimeters. Well, you cut that out, you say, well, how are you going to pull this tendon back down where it belongs? They'll go up even higher, so they'll make the incision even higher, and then do some fascia lengthening up high to pull the tendon down. And then they attach it, kind of like a rotator cuff repair. Classically, people now are using anchors, and you'll anchor it back down to the tendon. So, but what I've been doing lately, and we're doing a study now, is we make an incision down the center and we peel it back, but I peel back just enough to get everything that I want cleaned out. And my belief is even, I think it's a bulking problem. So you can imagine you've got a big bone spur that's coming in the back. You have an Achilles tendon that's thick, and you've got bursts that are inflamed, and so you got this big prominence in the back of the heel. And if you touch the skin in the back, it hurts. And I think these nerves are all being compressed. And so it's a debulking procedure, or thinning it out. So I centrally split everything, take that bone spur away. I cut out half of the disease thickness-wise, so I debulk all that. I take the bursa sacs out as well, and then I'm left with this extra skin that's easy to close, so I know I've debulked all this. And so I detach part of the Achilles tendon, but I suture it back with suture. I don't use anchors and try to avoid foreign bodies in the heel. And putting in these anchors isn't a benign process. I think you look at MRIs after a year out, you'll see some inflammatory changes in the bone with some of these anchors, specifically with a product called made out of PEEK. So I'm getting away from that a little bit. I think a lot of it's industry driven. So anchors are industry driven. They want you to use it because they're pricey. But I think there's a time and a place to use anchors that I do, but I classically try to stay away from that because I don't think it's normal to cut someone's Achilles off their bone entirely. And patients hear that and they just run. And so they come in, oh, you're not going to cut my Achilles off. I'm like, well, we're going to detach part of it. But you want to kind of debulk it is what I think. And I've been doing that now for about 10 months, changing the way I've been doing it. And we do quite a bit of these, and patients are doing right now very, very well.
And what's the post-op treatment for those two things? How long do you keep those folks restricted after either one of those surgeries?
So, again, the biggest concern is infection with these surgeries. So, because you got very little padding, but either one. So when I do just a debulking quick procedure, or we do something insertional-wise, I keep them protected right after from surgery in a half cast, immobilized, non-weight bearing for 4 weeks total. At the 4-week mark, and they have a cast change in between, but at the 4-week mark, the incision looks great. Then we put them in a walking boot with their crutches, and I have them start moving their ankles up and down at the 4-week mark for 2 weeks on their own, just moving their ankle. They can put some protected weight on it, maybe 25 to 50% weight bearing, but get their ankle moving nice. And then I get them in physical therapy at the 6-week mark. That way they've had 2 weeks to kind of move it around themselves. And then I get the therapist to work with them. They're in their boot still and their crutches, and then over the next 4 to 6 weeks from there, they start weaning out of this boot, start weaning off the crutches nice and easy. But it takes a while. It's a pretty good recovery time. I tell patients, on a safe side, it could take you 6 months to a year to fully recover. And they think, oh man, I'm not going to walk for a year. No, you'll be walking even in a boot at 6 weeks. But you want to give yourself a good 3 to 4 months to be comfortably walking in a shoe with some discomfort. I mean, even an NFL athlete tears their Achilles acutely, takes 30 minutes to repair. They don't play football again for 6 months to a year. So, and they're in really, really good shape. So someone that doesn't do that for a living, again, it takes a while to get back. But that's what I tell them.
And let's talk a little bit about the complete rupture. How do you tend to approach that surgically? How do you fix that?
So acute rupture, again, we tell them they need surgery. We try to get them done as soon as possible. And so, we make an incision a little bit off midline. We don't go right down the middle. We just, because it's not insertional part, it's up higher. We go off a little bit to the side. And the biggest thing is back to that onion deal, that the skin, so the peritoneum, the covering of the tendon itself, we really want to preserve that as much as possible because it has such valuable blood supply. So we preserve that, open that up, and then just take the two ends, and we suture those two ends back together with a special suture in a special way, but we suture those back together, so it's just an end-to-end primary repair. We do that, and then close up that tendon sheath really well so we have that tendon nice and protected by a good sheath. In a chronic situation where it wasn't really repaired and then you've left with this scar tissue in between, you cut out the disease part and you try to get an end-to-end repair, and then you can also try to augment with a tendon next door. So you're stealing from Peter to pay Paul, and you can augment with a tendon, but the surgical approach is essentially the same.
And how long do you find that it takes the complete rupture to recover? Is that longer than what you've just described, or about the same? It's
about the same, but again, even an acute rupture, they're much easier to repair at that point than chronic. But I tell them for sure, I mean, hey, 4 to 6 weeks of mobilization, and then nice and easy moving with a heel lift. But they're not gonna, they're not gonna typically be able to. When they can go run and jump is when you can stand up on both tiptoes, come off your good leg, and then slowly lower your heel to the ground. And they typically can't do that for at least 4 to 6 months. They feel pretty good, but you have them do that, they're like, man, I can't hold myself up. They don't have the calf strength yet. So, if you can't do that, then it's hard for you to run. So I protect them, 4 to 6 months, and I just go slow with them because that tendon will stretch out. If that tendon stretches out and it's repaired, they don't have the push-off strength, and especially from an elite athlete standpoint, it's that's a challenge for them. They can't lose anything. So you want to really make sure that tendon heals. And so there's a tendon that Dr. Andrews always sells, it heals faster with plaster. So keep them in plaster splint for a long time just to protect that tendon, let it get contracted. They can always loosen it up later once you start rehabbing them.
Well, I think this has been a wonderful discussion about all sorts of different Achilles tendon problems, from the fairly traumatic acute rupture to the, I would say, probably more common, just everyday tendinopathy that you and I probably have seen in our careers just over and over again. That is such a common problem. Anything that you feel like we haven't discussed at this point that patients ought to know about the Achilles tendon and the problems that it causes?
I think we covered most. I would just tell patients that, if you're having heel pain, don't ignore it, and go see a orthopedic surgeon or primary care doctor and get a workup done. And if you feel like they're not really discussing the things that we talked about today, get a second opinion. I would encourage you to educate yourself a little bit about biologics. I think these, the PRP, the platelet-rich plasma, and even stem cells, these kinds of things are kind of coming down the road here, and hopefully will keep patients from having surgery. And I think there's some viable options in some situations to use those. But early, I think an early treatment problem and an early treatment recognition and a good physical therapy with a good therapist knows what they're doing in a home exercise stretching program can try to help prevent these things. But especially in your weekend runners that run a lot and long distance runners, and then also the obese issue it's tough to tell patients they're overweight. I hate doing that, but when they come in and they have these bad Achilles problems and they're 300 pounds, that's a lot of load on the heel, and that's why they've got the problem. So, take care of yourself and get second opinions. But I think we did a pretty good job covering all these.
Well, I want to thank you for this information. I know patients will appreciate it, and I look forward to talking to you about different foot and ankle problems in the future. So thank you very much.
Oh, thank you, Randall. Enjoyed it.